All right. Hello, hello. I'm Dr. Kelly. This is Dr. Gonzalez on with us. And thank you so much for joining us today. I'm really excited to talk to you guys a little bit about, hormones and, just kind of what our program does. And just this is basically just a little, quick talk about, hormone replacement, perimenopause, the issues that, we're all struggling with and potentially how we can help. And so I'm gonna do a little bit of a talk, and then after the talk, which will be maybe 15 minutes, then I'll open it up for questions, and I can answer any questions that you have. Okay? Sounds good? Yeah. All right. All right. Let's roll. Okay. So, all right, just a real quick, a little bit about us. I'm Dr. Kelly. I'm an internal medicine and obesity specialist. And I've been doing women's health for a pretty long time. We have been in practice together since 2021 here, but we worked at a women's view before that. Dr. Gonzalez is a family medicine and geriatric specialist, and she has been in practice much longer than me, despite the fact that she's only like 5 years older than me. So
You had another life first.
she went to medical school when she was a child, I'm pretty sure. So yeah, we live in the area and we opened our practice, Emerald Health, in 2021 and have been on 4th Street since then. All right, so we're going to cover a couple things. I'm going to talk a little bit about the different hormones like estrogen, progesterone, testosterone, a tiny bit about thyroid hormones and how they interact, with the whole situation with the rest of your hormones. And then Dr. Gonzalez is going to tell you a little bit about our clarity visit, and we'll have some facts and then quick questions. All right. All right. So let's talk about all of your hormones. Okay, so the way that I think about hormones, in terms of, what they do, what they're there for. So the term hormone is thrown around a ton. So what hormones do in your body, and there are like bazillions of hormones in your body that your body makes with your cholesterol, basically. So the cholesterol is broken down and then it's made into all different kinds of hormones, which are basically the way that that different parts of your body tell other parts of the body to do things. So for instance, your thyroid hormone. Your thyroid hormone tells your muscle cells to work better or work less. You make another hormone called TSH, which is what we check in your blood every year. And the TSH goes from your pituitary gland to your thyroid hormone to tell your thyroid hormone to make more thyroid hormone, or tell your thyroid to make more thyroid hormone. With regards to sex hormones, we're talking about estrogen, progesterone, testosterone. We have two other ones that we measure sometimes called FSH and LH. You may have seen that on your blood work. So all of these hormones work together to tell your ovaries to make an egg. They tell your uterus to shed the lining or not shed the lining. And I'm going to get into that a little bit more. But so basically, all you need to know about hormones is that they tell different parts of the body what to do, and it's kind of like the telephone of the body. So, when the brain wants to talk to the uterus, it uses FSH and LH. All right. So estrogen specifically is the one we probably know the most about, So this is our primary female sex hormone. It kind of like makes females who they are. And it is integral in like every part of your body. Now, you're probably most familiar with how it affects your menstrual cycle, how it affects your uterus. So basically, what it does is it tells your ovaries to release an egg every month. And then, depending on how high or low it is, it affects whether that egg is used. or whether also it affects whether you even create an egg every month. But beyond that, it does a lot of other things. So it affects your secondary sexual characteristics. So it helps to produce breast tissue when you're young. It actually is integral in increasing the feminization of the face when you're young. So that means increasing cheek fat. It increases skin elasticity, and it also upregulates collagen production in the skin. So that's why young women have this like amazing, stretchy, beautiful, perfect like skin that all of us still want to have. It's because of all of the estrogen in their body. The other things that it does beyond the sex, the sexual organs is it maintains a healthy cardiovascular system. So, one of the things that estrogen is known to do is increase the amount of nitric oxide that is being produced in the body. And what that does is it vasodilates the blood vessels. So, high estrogen levels in the body improves blood pressure, and it improves the way that your entire vascular system responds to exercise. The other things it does is it regulates cholesterol levels, so it actually decreases bad cholesterol in the body. Again, it promotes skin elasticity, makes your skin beautiful. It increases your bone density, which is very, very important for us as we get older. So, with regards to bone density, we're talking about it decreases your risk of having osteoporosis. Um, it also affects your neurotransmitters, specifically serotonin and dopamine levels. So this is why when you right before you get your period, a lot of women will be very, very moody. And that actually has to do with the fact that we have a decreased level of estrogen. So the serotonin and the dopamine receptors are not stimulated as much as they are in the rest of the cycle. So then you get sad, you get anxious, things like that. So very, very important, for mood as well. So estrogen just does like all kinds of things. It's super, super important. And what happens in perimenopause with the estrogen level specifically is that it causes it to go up and down very rapidly. So when you're young, like 20, your estrogen level goes up and then it goes down throughout the month. And it's very smooth, and it's not jarring in any way. So, things work pretty well in your body with regards to your estrogen. But perimenopause hits, and then all of a sudden, 1 month, you have acne and your breasts hurt for no reason. And you're super moody. You want to like punch your husband. And that's because your estrogen's super high. The next month, you have like mild vaginal dryness and you're having hot flashes and at the end of the month, and you're like super unhappy and you're really again really moody and you can't sleep. That's because the estrogen has dropped through the floor. And so this starts really young. This is like probably 10 years before menopause. You start having wild changes in your estrogen levels throughout the month and throughout from month to month. And so women will start having these problems as early as about 35. And it may be pretty mellow at that point, but it gets, rapidly worsening over the next 10 years until you reach menopause. Now, a lot of women won't notice as many of these problems because they're on birth control pills when they're 35, when they're 40 years old. But if you have an IUD in, or if you do not have, are not on birth control, this is when you really start noticing this. And basically, most of the time you go into your doctor and you say, I'm having all these weird symptoms. I'm super anxious all the time, or I'm having hot flashes, I'm night sweats. My periods are really irregular. Like 1 month it's at 20 days. The next month it's 35 days. It's driving me crazy. Why am I having intermittent vaginal dryness? This is so weird. I feel so weird all the time. I stink all of a sudden. I don't know why. Like one month I'm very sweaty, the next month I'm not. And, most of the time the doctor will say, oh, well, you're getting older, and that's just not really what any of us want to hear. Well, you're just getting older, deal with it. Because it's very, very disappointing, that there's no, in the mind of, most of our doctors, and practitioners, that there's no fix for this. Now, another thing that happens with estrogen, which is a real bummer, as the estrogen levels decrease over time, you start to get an increase in visceral fat. So, what visceral fat is fat sitting around the organs. And so, this is that central weight that you start to gain when you're like, I don't know, 35, 40 years old. And this is also a real bummer because I have tons of women who come in and say, listen, I work out, I walk every day, I've never had this fat around my waist. And then, like the last 2 years, I have gained 2 inches of fat around my waist. And they're like, I don't understand why. I haven't changed my diet, nothing's changed. So that has a lot to do with, again, how estrogen affects the way that we deal with even, our carbohydrates. So we get an increase in insulin resistance as we go into perimenopause, and that causes this visceral fat to form. And what that does is it puts you at an increased risk of diabetes. Now, in the studies looking um, at menopause, women who do not take hormone replacement during menopause do have a significant increased risk of diabetes during that time period. So we do know that, estrogen is really protective for both diabetes and cardiovascular disease. All right, let's go to progesterone. Now, progesterone, oh, real quick. So I like to think of estrogen as like your ice cream. It's like the meat of the situation. It's the best part. It does all the things. It is like what you need in your life. It's the satiating part, okay? So now when we talk about progesterone's like the cone. Okay, it's like the structure. So what progesterone does in your normal menstrual cycle is it starts to increase halfway through the cycle, and it causes thickening of the uterine lining. And the reason why we want thickening of the uterine lining is in preparation to implant an egg. So in the second half of the cycle, we get thickening. And then at the end of the second half of the cycle, which is the luteal phase, if the egg is not fertilized, we get a dramatic drop in progesterone, which causes bleeding. So, in pregnancy, we get a maintenance of very, very high progesterone levels. And one thing that we found with women who are pregnant is that in the first 3 months of pregnancy, they sleep a ton and they are very calm. So, one of the things we know about progesterone is that it does affect the GABA receptors in the brain. And the GABA receptors are integral in managing anxiety. So progesterone levels that are high make you calm and sleepy. So when you go into perimenopause, one of the things that happens over time is that progesterone level decreases pretty rapidly in that 10-year period. And it's not as jarring as the estrogen, so it's not like bouncing up and down, but it is kind of coming down pretty fast. So that's another reason why you will have a lot of irregular periods during that time, because increased levels of progesterone stop the estrogen from creating havoc and making you spot. So as the progesterone goes down, you do get more spotting, you do get more irregular periods. But what you also get, especially right before your period, is like a week of sheer terror and anxiety. So a lot of women will say, gosh, all of a sudden I have 4 or 5 days right before my period where I like can't sleep. I feel like I am going to lose my mind. I am like, I have massive anxiety. based on absolutely nothing. I sit around and ruminate about conversations I had with someone I don't even know 2 days ago, and it's based in nothing. And then I get my period and it goes away. And so that actually continues until menopause, when a lot of women at menopause have that every single night, where they're like, I go to bed, I lay there, I can't go to sleep, I have super bad anxiety, I don't know why. I'm tired, I can't sleep. I stay up till 12:30 in the morning. I scroll, I do all the things, and that has to do again with that progesterone, that lack of progesterone. Now, a couple of other things that progesterone can cause is water retention, and it can also cause breast tenderness because of that unopposed estrogen. Okay. All right, so testosterone is another thing that I think we're talking a little bit more about. Now, traditionally, testosterone has been funny with women. A lot of doctors have traditionally said that women do not need to take testosterone in perimenopause or menopause because it's a man's hormone. But women make about a tenth of what men make. And this is a very necessary hormone in the female body in order to maintain muscle mass, in order to increase energy levels. It improves, your self-perception for some reason, probably because of the muscle mass and just general happiness feelings it gives you. It also improves your libido a lot. Currently, the only indication for testosterone replacement in women is in perimenopausal or postmenopausal women with what we call hypoactive sexual disorder, which means just, women who are not interested in sex. And testosterone depletion is a real problem in most women in peri and postmenopause. Um, Now, this we do know that testosterone does gradually decrease with age, and by 40, it's about 50% of what it was when you were 20. But, you know, a lot of women will say, gosh, even with the estrogen and progesterone added, I'm still having massive fatigue. I cannot build any muscle. I go to the gym 3, 4 days a week, and I still I don't have any guns. I don't understand why. This makes no sense to me. Or my libido is terrible, despite the fact that I'm working out, I'm eating well, I'm doing all the things I need to do. I just do not have any interest in sex for some reason. And then also some weight gain, despite improving that estrogen and progesterone level, sometimes is a problem with testosterone. Now, how do the thyroid hormones, interact here? So, one of the things that does happen with estrogen, increased levels of estrogen actually affect your thyroid hormone levels in the blood. So, as the estrogen levels decrease, you may actually get an increase in thyroid hormones in the actual blood, like just circulating around. However, for some reason in perimenopause, this is the most common time for women to have overlapping hypothyroid problems. It probably has to do, and this is just my opinion, I think it has to do with the increased inflammation that is going on in your body, due to decreased estrogen levels and increased stress on the body, which can affect thyroid function as well. Um, but this is something we always want to pay attention to because low thyroid hormone levels have very, very similar symptoms to perimenopause symptoms like fatigue, weight gain, hair thinning, dry skin, depression, and those like heavier cycles. So that's something that we always check and always pay attention to when we're doing hormone replacement. All right. Okay, so a little bit about I've been talking a little bit about the interplay of these hormones, definitely. So, a couple things that I just want to, point out real quick. So, when you're in pre-menopause, so like you're 25 or 30, if you have too much estrogen, what we call that is either you have heavy cycles or you could have endometriosis. And then other things that happen, kind of in that pre-menopause stage If you have low progesterone during that time, some of those women will have PCOS, but then you also see women who have that premenstrual dysphoric disorder, which means in the week before they have their periods, they have severe anxiety, they can't sleep. Sometimes they get almost psychotic. So you see again that lack of progesterone, really causes, problems with the GABA receptors, problems with mood. Now, in the perimenopause period, we have erratic estrogen and low progesterone. So things we see, are irregular bleeding, sleep disturbances, being irritable at times, really bad mood swings, fatigue, weight gain, insulin resistance, and a lot of women, including myself, have palpitations, which is super scary and super annoying. All right. And they come out of like nowhere. I don't even know why I'm having them half the time. And then, in your postmenopause period, you have low estrogen, low progesterone, and low testosterone. So everything's really low. And that's when you see vaginal dryness, you get chronic UTIs, urinary changes, painful intercourse, low libido, osteoporosis, loss of muscle mass. You have muscle and joint pain, which you can also see in perimenopause. And, a lot of times we'll have problems with indigestion for some reason as well. Um, and again, a lot of these postmenopausal symptoms you can kind of intermittently have during perimenopause as well. Now, real quick, I want to talk about the vaginal dryness and UTI situation. So, one of the things that happens that no one ever tells you about in perimenopause and menopause is when you have a lack of estrogen that is, in the vaginal canal, you actually lose the elasticity of the vaginal canal, and you also lose all of those glands that make lubricant. Um, the other thing that happens is all of the estrogen receptors and the testosterone receptors in the vaginal canal are turned off because there's no estrogen to turn them back on. And so what that ends up happening is the entire vaginal canal gets very slick and it also gets very tight and the skin itself gets very sensitive and thin. The third thing that happens is the pH changes. So the pH change makes you have an increased risk of UTIs. And so long term, we recommend that any women who have any issues with UTIs or urinary incontinence use vaginal estrogen because that vaginal estrogen will reestablish the correct pH and it will improve the stretch of the skin and it will also improve the thickness of the skin long term. Okay. And what's cool about vaginal estrogen is that you can use it with any other supplementation you're doing, so any other hormone replacement or by itself, because it's extremely safe. All right, so that was a lot of stuff. So one of the things that I think in perimenopause that is really, really difficult is that often your standard labs will look totally normal. And, people will say, "Oh, you look fine. Your, estrogen level was fine during this time," or, "this was normal or that was normal," and all of your normal labs are normal. Um, and sometimes you won't have hot flashes, and that's like the key word that, doctors are often looking for in terms of menopausal symptoms is the hot flashes. But there are a lot of other symptoms that women have before hot flashes. And a lot of times, the way that we define hot flash in our heads is like soaking, drenching sweat. And so women might not necessarily, report hot flashes to the doctor because that's not kind of what they're thinking is happening. Sometimes we're just hot all the time, and that is, partially the issue. So hold on real quick. I just realized that I had did somebody ask a question? Let me see here. Oh, no, that's you too. Never mind. Ugh, that's Dr. Gonzalez and Kirsten putting things in.
Yeah.
Sorry.
And just make sure there's no one trying to enter the room. We had some people register late.
Oh, okay. No, I don't think so. I think everybody's in.
Okay.
Okay. All right. Okay. So, the other thing, is that a lot of times providers will tell you that you're too young for perimenopause, especially if you're around 40. They don't really associate perimenopause, with anyone until you're close to 50 a lot of times. So, younger women will be ignored because of the fact that, that's just not in the purview of the doctor you're talking to. The other thing is that, this is complicated, and a lot of times women don't really know how to explain what's going on in their bodies. And that conversation takes more than a 10-minute visit to really, clarify. And in my experience, I've the conversations that I have with women who are in perimenopause or even menopausal symptoms, especially perimenopause though, is that, they don't have like the words to explain what's happening until we really start just dissecting what's going on in their lives. And these problems that we have in perimenopause are multifactorial. They're not only from, hormones. They're also, worsened by stress, by the things that happen to us in our 40s, they're worsened by, diet and exercise. And so all of these things are super important. And in, your normal visit, your 10-minute, 15-minute normal visit, it's just impossible to really hit on all of the, issues you have going on and all of the kind of interventions that you may need. Now, a lot of people are also, really concerned about the link between hormones and cancer. Now, in the clarity visit, that I have with patients, we go over what the data says, all of the, the safety data about hormones, just as a way to reassure that the relationship between hormone replacement and cancer is not it's not a causation relationship. It's not any relationship because we know that hormones do not increase your risk of cancer. Um, so, we're here to kind of fill that gap between your primary care doctor and, getting the care you need, during your perimenopause and your menopause, chapters. So, what we can do is provide ample time and the knowledge, that is necessary to give you next steps to give you a clear path and feeling better. All right.
Right.
What is happening? Okay. Oh, here we go. Okay, so if you're interested in booking your one-on-one clarity visit, this little guy right here, if even if you want to think about it or whatever, that QR code will take you directly, to the website that you can sign up for that. Okay. All right. So, Anne, are you going to talk about this?
Mm-hmm. Yeah.
Hit it, girl.
The clarity visit, which is what that QR code was for. If you can go back to that just for a second, in case anyone wants to take a picture of that, and there's a Bitly link down there, and then we dropped the link in the chat as well. So the clarity visit is a one-time visit. It's telehealth. We do have some patients who are local, but we also are able to do this throughout the state. So it is a telehealth visit. If you are in the Hickory area, you're very welcome to come into the office. But yep. So what we do is have you get your labs done. We will order it from a local lab core near you. And then we set up a time for us to talk to you about those labs. We go through your symptoms and your family history and talk about what kind of care plan you could expect if you were to come and join us for the full program, or you can take that plan to your doctor either your primary care or your OBGYN to discuss next steps. But the reason why we wanted to offer this is because, again, there isn't a lot of time in your like annual visit with your primary care or your OBGYN, and there's a lot of other stuff that they need to discuss with you that is preventive and is necessary as well. So the Clarity visit is $597. It includes your visit, your labs, and the lab value is actually over $1,000. So it really is kind of a good deal. And then you'll get your care plan that you can take going forward, or you can either, if you wanted to join us, you can apply that to the full program fee. We do have a full 12-week program where we have special weekly coaching, we have online resources, and it's just a really intense kind of education about perimenopause, menopause, your hormones, other things that affect you. So the difference between this and either, going to your regular doctor or even some of the other online programs that are out there for hormones is that, this Dr. Kelly and I are both physicians. We have been trained in this and we've been doing this for a very long time. So this is evidence-based medicine. This is not influencers. This is not just anyone off the internet. We do offer online scheduling. And again, it is telehealth. So, you can do this if you're at work, just block off some time and we can talk at that time. And the other thing is, Dr. Kelly mentioned, we are going through this. We are both in that perimenopause, or I think I'm right, just past the menopausal period. So, we can empathize. We know what you're going through, and not everyone can say that. So we are right there with you. Dr. Kelly, if you will move to the next slide, please. So if you've got any questions, I did try to kind of summarize those so that you can understand all there is to know about this program. Number one question we get is this covered by insurance? And no, we don't bill insurance because that allows us to take the time and to actually spend with you and discuss this adequately. Insurance-based practices, a lot of that is very volume-based. So we are able to actually, with being a cash pay practice, we're able to take the time, and we also can order the appropriate labs because some of the insurances they won't pay for some of these labs. And so that's one benefit of doing it this way. So you're going to get the visit, you get the full lab panel, which includes your kidney, liver, thyroid, your sex hormones, also insulin levels, hemoglobin A1C. So we're looking at other things beyond just your regular labs that you would get in an annual visit. And if you decide that you don't want hormones, that's okay. What we do is we just go through your options and talk about some other things that are available to you. We are really we're really into lifestyle medicine, which really, internal medicine, family medicine, it's primary care. That's really what lifestyle medicine is. So that's what we've been doing all along. If you've had labs with your primary care doctor, again, we order more comprehensive labs beyond what you would get in your regular visit. And we also look at them with, kind of thinking about perimenopause, because as Dr. Kelly said, sometimes these labs, they look normal, but for a woman, sometimes labs will look normal and they're just not normal. Specifically for women. And then also in perimenopausal times, those labs are kind of up and down, as she said. So you really have to understand and be looking for that when you get these labs.
Yeah, they're very contextual, so, they will be technically in the range of normal, but, together you have to know how to interpret them for like the period of time you're in, how old you are, what part of your cycle you're in, all of those things. And, that I'll tell you firsthand, that's not something that like a general internist or a family practice doctor would be necessarily trained in without doing, women's health training beyond what we learn in residency.
So can you, if you'll go, let's see, yep, next slide. So if you wanted to talk to your OB-GYN, this is great. I mean, if your OB-GYN is open to talking to you about this, wonderful. Please, stick with them and talk with them about this. But a lot of times, like I said, there's not a lot of time when you have your annual visit. And honestly, as Dr. Kelly was just saying, some of the doctors out there have not been trained um, in kind of the more specific medicine related to perimenopause and menopause.
Yeah.
So supplements, there are definitely supplements that we would recommend. But the nice thing about having us do this with you is that we can tell you exactly what helps, what doesn't help, what's evidence based, and that way you don't have to just kind of try different ones just hoping that it will work. And then after you have your visit, you do take a plan with you. And like I said, you can either continue with us for a full 12-week program, or you can take that plan to your regular doctor, your primary care provider, or your OBGYN and talk to them about what you would like. The other thing that we're going to give you after the webinar is we're going to send you a symptom tracker, which is really helpful when you do go take this plan to your doctor or your provider, because it helps when you go in for that visit to be able to say, these are the symptoms that I'm having. This is how often I'm having them. This is how long I've been having them. And then that way, that can help whoever you see figure out what is next, what else they can do to help you.
Mhm.
So I think now we've got time for questions. Let's see, I had some other questions from
Does anybody
earlier.
have any questions right now?
Let's see here. I have had these questions asked before. Um, there were a couple that were sent. Oh, so the we talked about a lot of these already. Like, why do my doctors say my labs are normal?
Mhm.
Um, oh, the labs, do they have to be fasting?
No, they don't have, well, yes, actually. So the only thing that is fasting on these labs is the insulin level. So we would want a fasting insulin level and a fasting blood sugar to calculate the like if the person is insulin resistant or not. So I would say, yeah, that's the only reason why. The rest of the hormones do not need to be checked at any certain time of day.
What about someone else asked, what's the difference between bioidentical and um, traditional, I
That's
guess
a
you would
great.
say, or is there a difference?
Okay, so until about 10 years ago, we did not have any bioidentical hormones that were FDA approved. So previously, we were using a drug called Premarin or Prempro, depending on what the preparation was. And so Premarin was a combination of conjugated um, equine estrogen. So that's estrogen that we got from the urine of horses, of female horses, and then a progesterone that was synthetic. So why is that problematic? So the estrogen portion is not problematic, but we do think that the progesterone in Premarin does have a correlation to a slight increase in breast cancer risk. So the difference between that and the bioidenticals is that the bioidentical hormones, both the estradiol and something called prometrium or bioidentical progesterone, have been shown to not have a relationship between increased breast cancer risk when taking either of these drugs. So generally, they're safer. They have a decreased risk of causing allergic reactions or inflammatory responses in the body. And that's really, we want to be as close to bioidentical as possible. So previously, people were using only compounded drugs for this, but we no longer need to use compounded drugs. So now we have two great FDA approved drugs that your insurance will pay for, that is really cheap to buy and really safe. Now,
So,
another thing
oh,
somebody asks me about a lot are pellets. I know that you probably, every single one of you probably have someone you know who has pellets. Um, I am I really, really, really dislike pellets a lot, and I would not recommend them to anyone because of the fact that you cannot remove a pellet after you put it in, and you also cannot change the dosing of the pellet over time. So what happens with a lot of women is they get a super, super, super therapeutic dose of specifically testosterone, which can have some negative effects over time and is pretty dangerous. So no to pellet.
uh, someone asked about the Dutch test.
Oh my God, I was just talking about the Dutch test. Okay, so all right. The, that's a really good question. So here's the deal. Hormone replacement in perimenopausal women has to do with symptoms. It doesn't have to do with your hormone levels. So, because your hormone levels are rapidly changing over time, right? So like, if I did like 15 tests on you in 15 days, I'd get 15 different levels of hormones. So, do you need to go and get a Dutch test done? It costs like $1,000. I don't think so. Because when you come into my office and you tell me I'm having all of these symptoms, they're consistent with perimenopause. You know, why do I need a test to tell me that you're in perimenopause? I already know that. And so, really what we're doing is dosing our medications based on your symptom relief, not on a lab test. Because the lab tests are, ever changing. So that's kind of my thoughts on the Dutch test. It's just really expensive. Um,
What about how long, if someone starts hormone therapy, how long does it take before they can start seeing an improvement in their symptoms?
that's a good question. Usually um, a month to 6 weeks. The thing, so I, one thing I do after starting people on hormones is recheck their estradiol and their testosterone levels within 6 weeks. And the reason why I do that is like one, testosterone does need to be followed over time because we do not want you to get into the super therapeutic range. But two, I like to make sure that the estradiol that I am giving the person is being absorbed properly. And so they do have a baseline, amount of estradiol in the body. So that's why I recheck estradiol levels, even if you're, having your symptoms have resolved. Okay.
What about would you recommend testosterone replacement for everybody?
Not for everybody. Depends on, some women have normal testosterone levels, even at 45. Oh, that's a good question too. So, okay, I do not generally, I do have a couple patients on compounded drugs. Somebody just asked, I'm sorry, I just jumped into that question like you guys could read it. Shay just asked, what's your preferred method of delivery for each hormone? Oral, troches, compounded, creams, etc. It's really patient dependent. So I usually start with topical, either transdermal or like something like Divigel, which is a systemic gel. The reason for that is that that's the absolute safest method of giving someone an estradiol replacement. Um, I tend not to use compounded drugs because there is a huge amount of variability in the dose from month to month, depending on who has compounded it. Also, I prefer FDA approved drugs because they have to prove that, each lot of drug is both safe and the dose that they're telling you it is. And so women tend to have less variation in their symptoms from month to month. So some women do require oral estradiol replacement because they just don't replace well with transdermal preparations, and that's fine. You know, some women don't do well with oral estradiol replacement, and that's where the either gel or the transdermal patches come into play. I have a couple patients on compounded drugs that do fine. It's really dependent on the person. With regards to progesterone, usually most people will take an oral progesterone at night. That's the easiest and cheapest way to take it. And 90% of people do absolutely fine on oral progesterone, prometrium, which is the bioidentical progesterone. With regards to testosterone, the safest way for women to take testosterone is transdermally. Almost, I think I have one woman right now, and I don't give her this, somebody else does, but she takes an injection of testosterone, and she's having an issue with like absorption of the transdermal testosterone, so that's why she's doing that. But that's the safest way to take testosterone as a woman.
What about um, how long how long can someone take hormone replacement therapy?
I mean, technically forever, so there really is, we used to say 6 years, that was like our party line. But the most recent guidelines from NAMS, which is the Menopause Society in the United States, says, basically however long you need to take it, maybe 10 years, maybe longer. Um, See how it goes, basically. They really are now pushing, individualized care as opposed to giving us like these 5, 10 year cutoffs like they used to.
Mhm.
That's a good question as
Will, will you talk a little bit about the preventive effects of hormone therapy? So it's not just to treat symptoms,
yeah.
right?
Correct. Yeah. So, the two biggest things that we see in terms of preventative is a decreased risk of cardiovascular disease and a decreased risk of osteoporosis. Now, the number one killer of women in the world and in the United States is heart disease by a lot. It's not like a little bit more than, say, breast cancer. Breast cancer, I think, is third or fourth on the list. So, we've been obsessively talking about breast cancer over the last 20 years, and then we have been totally ignoring the fact that most women die of heart attacks. Um, so, we really, really, really want to improve that cardiac, risk factor in women, because that's when you have heart attacks is postmenopausally. The other thing is it decreases your risk of diabetes in the first 10 years after menopause, which is very important, I think, as well. And then the thing that we know about the most is that it does decrease your risk of osteoporosis. And in women, osteoporosis is very serious as you get older because the risk of dying of a hip fracture in 1 year is 50%. So, osteoporosis is I think, kind of a silent killer, in older women. Somebody just asked me, when do you retest labs after beginning hard? Usually at 6 weeks. Well, it depends. It depends on the person. So it depends on if they're like cruising, doing great, 6 weeks to 2 months, I'll recheck. If we have made lots of changes over the first couple of months, I'll check at 3 months. Again, this is kind of why I think seeing somebody who is trained in hormones is really important because every woman is different. Every woman needs different things. And just like, lab tests don't necessarily need to be done XYZ, they need to be done when they need to be done, but usually 6 weeks to 3 months.
Is there ever a point where you're like too young to start hormones? if you start
Yeah.
early perimenopause symptoms?
So okay, so that's a really interesting question. So there's a lot of schools of thought there. So there will be people who will knee jerk and be like, absolutely yes. However, you would never bat an eyelash at putting a 35-year-old woman on birth control pills. No one would even ever even think twice about that. So why would you be concerned about putting a 35-year-old woman on a lower dose of hormones than a birth control pill because of the fact that, she is, quote, too young to be in perimenopause? I mean, the things with younger women, like with a 35-year-old woman that you'd be concerned about is that, she's not going to get birth control from hormone replacement. So you need to make sure that she is using birth control if she's sexually active. So you need to think about that. You may make her bleeding worse if you put her on, let's say, a transdermal estrogen patch as well. So you need to kind of think about that as well. So there are some things that you may like screw up her cycle a little bit, but like there's no real like increased risk of using bioidentical hormones in a 35-year-old woman, than there would be if you put her on oral contraceptives.
They said, Amen.
Somebody said
Agreed.
amen. Yeah.
So we're at just about an hour. So everyone who joined us, thank you so much for joining us. I hope that you learned a lot. We hope that it was helpful. And if this sounds like these are symptoms that you're having, whether it's sleep, brain fog, weight gain, we're here for you, and you don't have to do this alone. So there is the QR code right there to schedule the visit. That actually takes you to the webpage for the Clarity visit, so you can read more about it and then sign up. And if you know anyone who would benefit from, this kind of visit, please share this with them. We would love to help more people with this. And I think, yeah, that's it. We hope that we can help you. And just when you get your kind of follow up email from the webinar, if you have any other questions, please just reply. And again, share with others. And we hope to talk to you soon. Thank
And,
you. Thank you
and
for
is this
coming.
going to be posted? You said this is going to be posted somewhere or no?
Yeah, the replay is going to be going out afterwards in a couple hours. And then I think we will be able to put it on our YouTube channel.
Cool, cool. All right. Yeah. So if any of your friends want to listen, it will be on our YouTube channel. Yay.
Yep. And
All
that's our Facebook link and our email and the website. So thank you so much. And
right.
we hope
Thank
to
you
talk to you
guys.
soon.
All right. Bye.